I'd like to thank Dr. Partha Viswas sir for giving me this opportunity. Today, I'll be talking to you about a relatively new technique that we started using in case we landed up with no capsular support. Initially, we used to use sutures to support the lens if there was no capsular support, either a 10-0, 9-0 Prolin or of late Gore-Tex sutures. But this involved creation of pockets, introduction of sutures, tying those sutures to the haptics. It was a cumbersome long-term procedure. Dr. Agarwal introduced a new technique wherein the pockets were formed. However, he used the haptic of the IOL, created pockets, what are called as chariot pockets, and then inserted these haptics inside the pockets. That's what he did, called it glue and used glue to fixate it. However, a new technique around 3 to 4 years back made its way by Dr. M.N.A., wherein he again used the haptics, but instead of creating a pocket, just introduced a 30 gauge needle, introduced the haptic into that 30 gauge needle. It used to simply fit. These were PVDF haptics. And then introduced the second needle, engaged the second haptic, the trailing haptic. We will be talking about this in detail, how to engage it, but just to show that this was a new technique that he proposed and simultaneously looked for the centration and then simultaneously brought out the two needles. This is called the double haptic method. And then used heat cautery. This was Bowie cautery, created flanges in the haptic of the IOL, and just used these flanges, pushed it inside the sclera so that it was supported in the lamellae of the sclera. In India, number one, the haptics that we were getting were not fitting into 30 gauge needle. So we had to resort to certain other new techniques. What did we do? Now this was a case of referred from outside, a case wherein the nucleus had sunk inside. So we did a vitrectomy, removed it. Here we're using a 27 gauge needle, a PMMA 3-piece lens, specially made, available only with the Aurolab nowadays. And of course, one more labs also. This was Aurolab lens. It was quite easy to perform this leading haptic. Looked very easy. And then again, the trailing haptic was taken inside the eye and it was engaged. This is an edited video, but I'll show you it was quite difficult for this trailing haptic to be implanted. So what are the techniques we tried to use is what I'll be showing later, how we modified it. As a corneal surgeon, I prefer to mark with these kind of instruments so that the exact centration is obtained. Point to be noted, always there should be a 2 millimeter away from the limbus and 2 millimeter away from that point so that a proper track is obtained and the haptic can be held there. If you carefully notice, this bevel is pointed towards the IOL and then the haptic is captured into that bevel, further strengthened by pushing it inside and then taking it out. A simple cautery, if Bowie cautery is not available, heat cautery can be used. The only thing we have to make sure is should not touch the haptic. Now the problem was always happening in the second haptic. These are edited videos, but this was the first ever surgery I did. And here if you notice that the bevel is upside, captured and brought out. So how do we manage this trailing haptic situation? Now here is a case, more than 270-degree dialysis with, you can see that the sphincter is ruptured. Of course, remove the cataractus lens, do a thorough vitrectomy that is required in any case of vitreous loss or in any of these cases. Look out for the center. As we gain experience, no need to mark it. Just with the help of a needle, we can decide it 2 millimeter away from that point, create a track in the sclera, capture the haptic. You can see that the bevel is towards the haptic. Bring it out, and the first modification most of us are doing is we create a flange on this so that we do not lose this haptic. Remember, we are using 27 gauge lenses. The haptic does not snugly fit inside. So using a double haptic method would be difficult in these scenarios. Now, second haptic, the problem was in taking it inside and inserting into the bevel of the needle. So how did we modify it? Simple, bring the needle outside. Many people were doing it, but I learned it from Dr. Divyansh. Slowly, the haptic is brought out. It becomes very easy now. Once it becomes an extraocular procedure, most of us are very versed with this. Cautery is used, flange is created, and just pushed into, make sure that the centration is good, and push it into the scleral lamellae. Now, this is a case where I'm showing the pupillary reformation also, just to show how stable this particular lens is. 3 sutures have been applied, and then pupillary reformation is being done by the popular SFT technique. Now, I've did more than 20 cases, including the first one, which I had to do it in a 2-staged manner because of certain technical problems. Almost 2.5 to 3 years follow-up. The first case, I think, is more than 2.5 years now, nearly 3. And no issues as of now, till now. Also, very little manipulation, faster surgery, no need of extra sutures or any other special instruments required for it. I showed with the 26 gauge micro forceps as well as with the McPherson. Thank you for the opportunity.